Good afternoon, everyone. Thank you for having me and giving me this opportunity to be a part of this wonderful conference. I'm sorry I couldn't be there in person, but a heartfelt thank you to Dr. Shabir Chikani, Dr. Dhaval, and Dr. Nilesh for letting me do this online. I'm going to be talking about bariatric surgery as a treatment option for obesity, with special focus on patients with bone and joint related issues. This is some of the work that we've been doing over a period of years, and this is our team. Starting with the case of a patient who weighed about 262 kilos with a BMI of 90.6. If you see this patient in the standing position, you can see that there is a lot of weight on the torso, but hardly any weight in his legs. So there is a lot of weight bearing that is happening on the knees. And today, obesity is one of the most important risk factors for the development and progression of osteoarthritis. This leads not only to overloading of joints and destruction of the articular cartilage, but there are also additional mechanisms which have been implicated, like insulin resistance, adipose deposition, and improper coordination between innate and adaptive immune response in the development of these joint related problems. We also see another set of patients which have disabilities, especially patients with polio, where obesity is a major and functionally important problem, and which compounds the mobility issues even further. This is another patient who had avascular necrosis of bilateral hip joints at a very young age. She actually needed to undergo a total hip replacement at a very young age of 29. And she underwent bariatric surgery a few months back with us, and is preparing for the replacement of another hip. And the AVN actually was a result of continued steroid administration, because she had a very severe episode of COVID infection at that time. Now, these are a few pictures that I would like to share with all of you, which is something which we see very commonly in our practice. These are patients who come to us, and we tend to focus a lot on their other problems like their diabetes and obstructive sleep apnea and hypertension and all the other issues which are related with obesity. This, I would say, is one of the neglected aspects of obesity, which actually adds to a lot of morbidity in their life. Obesity is a contributing factor to soft tissue damage and osteoarthritis, especially the hip and knee joints. And we all know that people with obesity are much more likely to need a knee replacement. And even when they do undergo any kind of surgery, especially a knee replacement or any kind of joint replacement surgery, the risk of infection and prosthesis failure is also very high. They are also more prone to get any kind of musculoskeletal injuries like fractures in the lower extremities and meniscal tears, etc., when they are made to exercise too much, which is very common to see. When we see patients in our practice, they come to us and they've usually tried their level best to lose weight by going to gyms, and the trainers are actually pushing them very hard, and they end up getting these kind of injuries. Even in cases of trauma, they're more likely to have medical complications and more likely to have increased mortality. These are the recommendations of the American Association of Orthopedic Surgeons, and specific to patients with BMI more than 40. Now, they say that in these kind of patients, one must consider carefully the impact of weight on possible complications and results after surgery. And these patients are strongly advised to lose weight before surgery. And it is in the best, sometimes it may be in the patient's best interest to actually consider delaying certain surgeries and to uh, lose weight and come back and participate in a weight loss program before they actually undergo surgery. Now, these are patients that we routinely see in the practice. These are the kind of legs, just sharing a few more pictures of the lower limbs. And these are the patients who actually kind of have a lot of mobility issues and eventually become bedridden and are not able to mobilize by themselves. So, when as doctors we advise these patients to lose weight, most often what we don't advise is how to go about it. And very often it is not because we don't want to advise them about how to go about it. It's also because many times we ourselves don't know how to go about it, because obesity is a very complex problem. There is a whole lot which is available today to treat obesity, but we need to have some method to the madness. And these are all the available therapies for weight loss. And I would like to spend some time here on this particular slide, because I feel this is the most important slide for this presentation. Now, the available therapies here are multi-component intensive behavioral intervention, which is basically your diet and lifestyle modification. Then we have prescriptive nutritional intervention. Beyond that, we have pharmacotherapy. So we've been hearing a lot of conversation about drugs like Ozempic, drugs like Wegovy. Then we have endoscopic therapies like balloons and endoscopic sleeve, etc. And at the top of the pyramid, we have surgery. Now, what we need to understand is that each therapy has a particular weight loss percentage that a patient can achieve. It's very hard for a patient to achieve 40% weight loss with just diet and lifestyle modification. So, diet and lifestyle modification will have a limitation when it comes to total body weight loss. So, the amount of weight loss that we are expecting is about 2 to 5%. With prescriptive nutritional intervention, what we expect is about 5 to 10% goal of weight loss. Pharmacotherapy can lead to about 5 to 20% of total body weight loss. Endoscopic procedures would be similar, and bariatric surgery can actually lead up to 40% of the total body weight loss. What is important to remember is that the treatment intensity should increase with increasing body mass index, with increasing health risk, and increasing adiposity. If a treatment is not working for at least 6 months, we need to review and we need to escalate therapy. There is no point in telling a patient to persist with a particular therapy, even if it is not working. Because if something is not working and we do not escalate therapy, then the patient will experience complications of the disease, which is in this case is obesity. Coming to bariatric surgery, there are, of course, a lot of myths about bariatric surgery. We all know people think that surgery is unnatural. People feel that they can't enjoy their food again. They feel that they will become weak. They will die after bariatric surgery, or they will have continuous vomiting. Some people actually feel that they will lose weight immediately after surgery. People feel that they will have complications like hair fall, they will look very old and haggard. There is a lot of confusion between bariatric surgery and liposuction as well, and many other things. But all said and done, today, bariatric surgery is the only proven method for long term weight loss for patients with clinically severe obesity. Surgery is almost never done by the open technique. It's almost always done laparoscopically. Now, it can also be done robotically. Sometimes we can also do it by single incision through the navel in some selected cases. These are the common procedures. We have the most common procedure is sleeve gastrectomy. Almost 70% of bariatric operations done in Asia Pacific region are sleeve gastrectomy. Then we have the Roux-en-Y gastric bypass. About 12 to 14% procedures which are done across the world are Roux-en-Y gastric bypass. And the third most common procedure is the one anastomosis gastric bypass. It's a technical variation of a gastric bypass where instead of a Roux anastomosis, we would have a loop anastomosis. How these procedures act is by restriction of food intake. Initially, the food is restricted. The patient would be able to have only about 25% of their usual intake at one go. They feel full very early, so the satiety sets in very early. But the major change which happens after bariatric surgery is hormonal. So a lot of GI hormones go up and down. The appetite hormone goes down. The other hormones like GLP-1, PYY, GIP, etc., they go up. And this has a lot of impact on the patient's satiety, on the patient's appetite center, on weight control, on glucose control, which results into correction of a lot of things in their uh, body. Now, these are a few other procedures. Almost 97% of all procedures are constituted by those three surgeries, which I showed you earlier. The remaining 3% of all procedures would be constituted by these other procedures, which are less commonly performed. These 3% would also include endoscopic therapies like balloons and endoscopic sleeve, etc. They are there, but not as popular, and the results of weight loss are also less. Plus, they're also not very durable in their weight loss. But yes, for a certain patient population, especially if the BMI range is lower, these form a good bridge therapy. And the advantage is also that they are reversible, and hence patient has that advantage of reversibility. And if they don't want to go in for a surgery, at least something is better than nothing. Now, when we talk about indications of bariatric surgery, these are the guidelines of the Obesity and Metabolic Surgery Society of India. Anybody with a BMI greater than 35, with or without the presence of any other obesity related comorbidity, is an eligible candidate for bariatric surgery. Anyone with a BMI more than 30 in the presence of two comorbidities can be considered as a candidate. If a patient has uncontrolled diabetes despite optimal management, medical management, and the BMI is more than 27.5, they may be considered for metabolic surgery. Surgery is the age criteria would be 18 to 65, but it's not a very hard cutoff. If we feel that a younger patient, an adolescent, or even a pediatric patient needs surgery and there is no other option for weight loss, and obesity is actually a life-threatening issue in that case, then a surgery may be considered. In for higher age limit, if the patient is medically fit and we feel that the surgery will make a difference to their quality of life, then we can consider surgery. In terms of contraindications, if a person is not able to take nutritional supplements, because all our surgeries are altering the GI tract, we are affecting the nutritional absorption to some extent. So, nutritional supplementation is a big part of bariatric surgery. So, patients who are unable to take nutritional supplements should be a contraindication for surgery. Rest are basically general contraindications, like anybody who's medically unfit, anybody with a non-stabilized psychiatric disorder, anyone with a drug dependency, anyone with a short life expectancy, anyone with a stage 4 cancer, or any lady who wants to conceive within 1 year after surgery should not be recommended to have a bariatric surgery. The BMI cutoffs have recently been lowered even further, and now a BMI of 25 or above is considered as obese for the Asian population. Now, coming to patient selection, there are basically, it's a very intense discussion between the patient and the team about which procedure should be done for them. In general, if a patient has GERD, or if there is hiatus hernia or Barrett's esophagus, then a sleeve gastrectomy would not be recommended, because sleeve is a refluxogenic operation. Otherwise, a sleeve is a good operation. We also see a little higher incidence of weight regain after sleeve gastrectomy, but then there is a lot of inter-individual variability in response to treatment, and there are patients who maintain weight for 10, 20 years as well. And then there are those who have regained weight in a short period as well. When it comes to bypass, it's a very good procedure. The only requirement is, because we are bypassing the duodenum, we are bypassing the stomach, the patients need to be on supplements lifelong. So if a patient is not compliant for nutritional supplementation, then I think a bypass should be contraindicated. Otherwise, for all other patients, bypass is a good procedure. Mini gastric bypass is a little bit more malabsorptive, so the nutritional supplementation requirement is much more, and sometimes there can be issues like diarrhea, etc. In my practice, I would go for a single anastomosis gastric bypass if the case is very difficult, and if I feel that I need to finish it faster in terms of reducing anesthesia time, then I would go in for this particular procedure. Of course, preparation is a very important part of our practice, because most of our patients are very high risk. So in people's mind, the perception is that obesity is not a disease, but we know that patients with obesity are actually a very high risk population and they have multiple comorbidities. So they need to be prepped properly, and better the optimization prior to surgery, better are the post-operative outcomes. We also put them on a pre-surgery diet. We evaluate them, investigate them, cover their nutritional deficiencies. We aim to make them lose at least 5% of their total body weight loss before the surgery, so that the chances of complications are lower and their post-operative outcomes are better. These are the outcomes, and if you can see these pictures, you would get a sense of what kind of change the bariatric surgery would bring in to our patients. Some of these patients are very old, some are very young, some are middle-aged, but in general, my favorite outcome after surgery is the quality of life outcome, the psychosocial element. They all become very confident. Most of them become happier in life. In case of older patients, and in case because we're doing a joint specific conference, what they gain is independence. So most of them are actually bedridden, and even for small things, basic things in life, they are dependent on their family members and they need support for every small thing. Most of our patients come and tell us that before the surgery, the person would never step out of the house. And after the surgery, once they've lost weight, they would never stay in the house. So that is the difference which weight loss brings in their life. And they are actually able to reclaim their life. They're able to get a second chance at life after losing weight. Now, in terms of outcomes and numbers, surgery at the end of 1 year would lead to about 30 to 35% of total body weight loss. There is some weight regain over 5 years, and on an average, people maintain about 23 to 27% of total body weight loss. Diabetes remission is very good. Most people maintain about 86 to 83 to 86% of remission, and so is hypertension and dyslipidemia. The all-cause mortality after bariatric surgery ranges between 0.07 to 0.15%. So the mortality rate is actually extremely low. When we talk about joint-specific improvement, this study was a 7-year study of the durability of improvement in pain and physical function, and it was seen that despite aging, participants experienced significant clinically important improvement in body and joint specific pain and physical function even after 7 years of surgery. This is a 31-year follow-up of a controlled intervention study after bariatric surgery for osteoarthritis and arthroplasty of the hip and knee in Swedish obese subjects. And here they found that there was a lower incidence of hip osteoarthritis in the surgery group, although knee arthroplasty was more common in the surgery group, which could probably be explained by the fact that patients after losing weight would probably be better candidates for knee arthroplasty, and hence surgeons were more comfortable in offering knee arthroplasty to these patients. Coming to complications, it's a GI surgery at the end of the day. Any GI complication can happen in this surgery as well. So we have leaks, we can have hemorrhage, we can have any other complication. Nobody likes complications, and complications is the reason why I'm not there today. I had to stay back and I couldn't attend the conference in person. But having said that, overall complication risk is less than 2% after bariatric surgery. It's actually lower than other advanced surgeries like esophagus surgery or cancer surgery or say cardiac surgery. There is definitely much better technology available today. There is a lot more experience today, and laparoscopy has made it much better and much safer for our patients. They actually get up and walk within 6 hours and they're home the next day. And we also have much more experience in managing complications, and I can say confidently that today mortality after any complication is much lower compared to what it was 10 years ago. So, obesity management is definitely beyond bariatric surgery alone. The journey starts with bariatric surgery, and we need repeated counseling sessions after surgery. Our follow up is lifelong, and at every follow up, as a doctor, as a part I mean, other than being a surgeon, it's a very important part of my profession and my specialty to keep motivating these patients for a sustained lifestyle modification. And we need to keep implementing techniques to increase compliance, because we need them to take their supplements, we want them to take their protein, and we want them to be motivated for exercise and everything. So we organize a lot of support group meetings as well. And what I always emphasize to my patients is that the goal of bariatric surgery is not just to chase weight loss, but it's to get a better quality of life, and it's also to prevent future obesity related complications. So, um, surgery is also now covered in health insurance from the year 2020, and our patients can actually claim cashless insurance as well, and that has been a big help to all of them. So, obesity is a very complex problem. We are still struggling with the fact that people do not consider this as a legit disease, and hence there is always that um, hesitancy to get treated, to seek help for getting treated. Everybody thinks that they can treat themselves by going on the net and taking reading a diet and just following that. But I think things are getting better. There is more awareness, and we're expecting a lot of new medications also which are coming in the market, which will actually help us to treat our patients better in future. So thank you very much once again for having me, and if there are any questions, I would love to take them. Thanks a lot.